Hi, everybody. I'm Professor Avijit Banerjee, and it's honor and privilege to speak to you today at the ACFF Global Summit, talking about Minimum Intervention Oral Care, or MIOC, the delivery framework in the post-pandemic era, really concentrating on caries management. I am the co-chair of the UK chapter of the ACFF, and I also work at the Faculty of Dentistry, Oral and Craniofacial Sciences at King's College London, which you can see here on the screen, this tall building in the southeast part of London. So what I'd like to do in the next few minutes is talk to you about minimum intervention oral care, which is a term you may not have heard of before, but you will understand it when you hear about it, which is this contemporary patient-focused, team-delivered approach to maintaining lifelong oral health. And as I said in this presentation, we're specifically talking about caries. We'll describe the four interlinked clinical domains that underpin minimum intervention oral care. And we'll also highlight the scientific, clinical, and consensus evidence for the different regimes for primary, secondary, and tertiary prevention. And at the end, I will cover a little bit about postgraduate education in this area with a distance learning master's that I run at King's College London in this subject. So what are the contemporary caries management issues that we face, especially since the pandemic? Well, we know from the WHO Global Burden of Disease study that has been carried out over the past few years, dental caries in adults and children creates a significant healthcare burden. As I'm sure many of you are aware, dental caries affects nearly 3.5 billion people on the planet, and this is untreated dental caries. And if you include children, it's actually pushing up to 4 billion people, which is quite a scary thought. And this is a non-communicable disease, as we know, but it has massive implication on general health, as we can see from the graphic on the right-hand side of the screen there. There are a couple of references also that I would guide you to give you nice overviews of this whole contemporary problem that we face. We also know that if we take mean population data sets and look at mean data, either regionally, nationally, or even internationally, this mean data really hides the disease complexity and it skews distributions. We are acutely aware of this, especially with the pandemic that we've just been going through, where we've been bombarded with data, and how that data is interpreted is everything. And one has to be very careful when looking at caries incidence and prevalence in that regard. We are acutely aware that there are socioeconomic inequalities that again have been exacerbated by the pandemic in the last 18 to 20 months. And certainly in the United Kingdom, this has been shown very graphically in the lack of treatment that has been undertaken by many millions of patients in the country. And this will, of course, start to affect oral health status adversely. So this access to care is a critical feature. As I mentioned, we know that dental caries is a non-communicable disease as classified by the WHO, but it is associated with other general health conditions, as I've mentioned on the screen here, diabetes, obesity, metabolic syndrome, and others. And it is really important that we bring the mouth back into the body and not manage oral health and dental health separately from general health. It has to be seen as one of the same package. And we know that dental caries is a preventable lifestyle-related condition. It really is down to our patients to cure themselves. And we, as members of the oral healthcare team, are there to help our patients do this by looking at behavior change, prevention-based regimes. But we have a problem. In many countries, there is still a traditional outlook on dental management and tooth decay management, and practitioners are really paid to treat disease rather than prevent it. So we need an overhaul with our stakeholders to look at healthcare systems and funding to ensure that prevention is encouraged throughout the life course of the patient. So we're really moving away from the traditional sort of conventional approach to caries management, which was the sort of drill, fill, and bill approach, to a more contemporary minimum intervention approach, where we try to prevent the problem from occurring in the first place. And we put the patient right at the center of this. And this is where I define the terms minimum intervention oral care or oral health care, as you can see here. You can read the definition on the screen. It's that overview. It's a care delivery framework that has 4 clinical domains, where we look at disease detection and diagnosis, or identifying the disease. We need prevention and control of disease. We need to think about minimally invasive operative treatments, and then recall consultations with the goal of maintaining lifelong oral health. You heard me say minimally invasive operative treatments, because that's where MID comes in, minimally invasive dentistry. This is one of the clinical domains of minimum intervention oral care. People use these terms synonymously. Minimum intervention dentistry, minimally invasive dentistry. They both have the same abbreviation, but they mean different things. And this is so important, which is why it's better to use the above definition of minimum intervention oral care to separate the two out. And in minimally invasive dentistry, as with all surgical interventions, they should be biological, respecting and preserving healthy tissues, and being as minimally destructive as possible. And therefore, there is a huge area of interest in the technologies and the materials that we should be using to actually practice minimally invasive dentistry effectively. So we're moving away from being the dental surgeon who cuts holes in teeth and does operations, to being an oral physician who's actually managing the patient as a whole. And on the right-hand side of the screen, you can see a couple of editions of the British Dental Journal, the top one in August 2017, the bottom one published in October 2020, which are minimum intervention themed issues that I had the pleasure of editing and contributing to. And there are probably about 20 different publications in those 2 journals that summarize the evidence behind what I'm talking about. So if we think about this graphically, we can see a depiction here on the screen of 4 cogs that are interlinked and turning simultaneously. And that really is what minimum intervention oral care is all about. This is a sort of graphic representation of MIOC. It's patient-focused, and it's delivered by all members of the oral healthcare team, not the dental team. Again, that's traditional terminology, and it's probably outdated. We're actually members of an oral healthcare team because there's so many different skills involved now. And here you can see the 4 domains. We have the domain of identify, where we actually detect and diagnose disease. We do risk assessment. We work with the patient to develop a personalized care plan, and we bring in primary and secondary prevention. We want to prevent lesions and control disease. And this is done by patient behavior management, looking at non-operative and micro-invasive interventions that are primary and secondary. And if you notice within these domains, I have oral health educators, dental care professionals, therapists and hygienists, reception staff, extended duties dental nurses, obviously the dentist. Every person in that healthcare team is involved in delivering that message and treatment. Another domain is the minimally invasive domain. So this is where MID comes in, minimally invasive dentistry. It's that restore domain when we actually perform treatments. And this is usually under the guise of tertiary prevention when a patient is presenting with a cavitated carious lesion. And a dental therapist or the dentist can get involved here. And you wrap this whole package up with the recall consultation, that long-term monitoring, maintenance, review, and reassessment, again, done by all members of the oral healthcare team. And also, within the last 18 months, we've had to use teledentistry a lot more with online consultations, and perhaps we should embrace that a little bit more and interact with our patients better to improve access to our patients rather than just face-to-face consults in the clinic. There are some, there's a book on the right-hand side looking at risk assessment there that I wrote a chapter in, and again, some relevant references. And there are some QR codes on the screen that if you scan with your phone app, should take you to relevant websites and PDFs online for further information. But as I've said, we're talking about minimum intervention oral care, MIOC, to do with caries management in this presentation. But the beauty of this framework is that it applies to the whole of dentistry and the whole of restorative dentistry. So you can see the identify domain can include periodontal disease, tooth wear, trauma, etc., etc. Prevention and control, again, the main disease processes are caries and periodontal disease, and also tooth wear problems that many of our patients face due to their acidic diet. In terms of minimally invasive treatments, these not only do they apply to direct restorations to sort of manage carious lesions, but also indirect restorations. There's minimally invasive root canal endodontics and prosthodontics. And in periodontics, we're looking at sort of professional mechanical plaque removal, PMPR, which is the new terminology of root surface debridement, and Hall crowns in pedodontics. These are all examples of minimally invasive operative interventions within that clinical domain of MIOC. And of course, as I mentioned, this is wrapped up with recall and looking at behavior change and management. So the MIOC framework really is an umbrella across the whole of restorative dentistry, but specifically can be applied to caries management, of course. So when we talk about primary, secondary, and tertiary prevention, what do I mean? Well, as I'm sure you're aware, primary prevention essentially is taking a healthy patient and keeping them healthy. And you do this by making sure their behavioral management is good, that they're aware of their behaviors, that they can adapt them, looking at their diet, their plaque biofilm control, oral hygiene control, and possibly using mineralization agents, fluoride toothpastes, this sort of thing. And this is all, again, inculcated with longitudinal caries susceptibility, and I'll come back to that in a moment. Secondary prevention is when a patient presents with early signs of disease that can be reversed and be taken back to health. And in caries management, we're really looking at what I've just mentioned in that first bullet point, but we can add infiltration technologies and even sealants to sort of seal off very early lesions and allowing the tooth structure to essentially heal and remineralize. Once the cavities have created and the lesion has spread further through the tooth, then we really have to operatively intervene to prevent further damage being done. And that's really what tertiary prevention is. And there is a reference at the bottom of the screen there that I will come back to when to intervene in the caries process. This was an expert Delphi consensus statement published a couple of years ago in Clinical Oral Investigations, but also I sort of rejigged the paper for the UK market for the British Dental Journal that was published in the MI themed issue that I just mentioned. So one of the key aspects of MIOC is looking at longitudinal caries susceptibility of our patients. Often people look at caries risk assessment as a snapshot. They ask a few questions, they note it down, and they feel that the risk assessment is done. It isn't. It has to be longitudinal. It has to carry on throughout the patient's life course. Does it have to be done face-to-face? Not necessarily. And this is where we can use technology to our advantage. And with future monitoring of intraoral environment, there could be scope to have sort of really quite large data sets that are being updated continuously to give feedback to our patients as to what's happening in the mouth. We can see an example of some of the key questions on the screen that should be asked, depending on the sort of patient demographic you're looking after. And there, of course, are several caries risk susceptibility assessment technologies and tools out on the market. But the key point is to take these readings and assess them longitudinally to see how things change and adapt. And I think that's a really important message. And the book chapter in the textbook of risk assessment in oral health that I co-wrote with Svante Tvetman really highlights this point in a lot of detail there. So as I mentioned, primary and secondary prevention is looking at non-invasive and micro-invasive interventions. So we're looking at the patient's oral hygiene control, biofilm control. We're looking at the surface mineralization. Are they using fluoride dentifrices or other mouthwashes? Or could we add and supplement that with other mineralizing agents that are on the market? Of course, patients are in control of their diet and what they consume. And all of these things are sort of non-operative or non-invasive measures that can be used as primary or secondary caries prevention. Those patients that have lesions, then we have to do the micro-invasive interventions, as I mentioned, fissure sealants, therapeutic fissure sealants, for example, or preventive fissure sealants, and also resin infiltration techniques. But there will always be a mixed methodology here, depending on the individual that's seated in your clinic or that you're speaking to online. And really, these primary and secondary preventive protocols rely on the behavioral psychology that we have to work with our patients. This is complex. We often worry about the treatments we provide to patients and the clinical skills we require. But actually, there is another set of skills we require in being able to talk and communicate with our patients and being able to influence how they think and how they behave, especially considering we're talking about a condition that is behavioral and it's lifestyle related. So using this COM-B model that was sort of published over a decade ago now, we can start to approach our patients in a slightly different way, rather than just informing and instructing and telling patients what to do. We can actually work with them to facilitate and engage with them so they are proactive in making the changes themselves. And there are three aspects. We need to look at the capability of the patient, their motivation, and the opportunities they have. What do I mean by that? Well, the capabilities are the physical and psychological sort of skills. Do they have them to be able to perform the behavior itself, the behavior change? Are they motivated to do this? And there are the conscious and automatic processes that we all have that drive us to wanting to behave the way we do. And again, we can potentially influence that with information that we can provide to the patient. And of course, the patient requires the opportunity to change their behavior, both physical and socially. They need the environment to be optimal so they can then engage with new behavior patterns that can then modify risk of getting disease and how the disease progresses. So all these aspects join up to actually ultimately create behavior change. There's obviously a huge amount more we can talk about in these areas, but because time is limited, we are moving on now onto tertiary prevention. So this is the minimally invasive operative interventions. If you remember that third clinical domain of minimum intervention oral care, where we're actually going to go in and start to operate on teeth and on cavitated lesions. But there are key critical factors that we have to think about to decide when we are actually going to intervene, which is why that paper at the bottom of the screen is so important, because this paper actually outlines all these things for you in a nice systematic way. If we're going to look at lesions that we're going to think about operatively intervening, we need to assess their activity. We need to know and assess their cavitation level and also how cleansable the cavity is. And as you can tell, all of these three factors are interlinked. If a lesion is cavitated, it is likely that the patient will not be able to disrupt the biofilm that resides on that within that cavity. And if it doesn't, if the biofilm is not disrupted, it will stagnate, it will become dysbiotic, and it will become cariogenic, which means the caries process within the biofilm becomes active. So you can see how these features all sort of link up. And these are the areas we need to assess to make our clinical decision as to whether we're going to sort of cut into teeth. And if you think about how these concepts have changed over time, you know, I've been qualified over 30 years, and I remember being taught about GB Black's cavities, class 1, 2, 3, 4, 5, which are essentially shapes of cavities within teeth. We talked about extension prevention. If there's a tooth with a lesion, you would sort of cut into healthy parts of the tooth that may be susceptible in the future. And this was because we didn't appreciate the difference between the caries process, the sort of the pathological process, versus the lesion, which is the manifestation of the caries process. And we thought at the time that the carious lesion was the process. It was the driving force that caused patients to have more and more lesions. We now know that's not true. It's actually the biofilm that's critical. And therefore, our perspective has changed, that we don't need to cut away lots of tooth structure. We can be minimally invasive, but the key thing is making sure that the biofilm is disrupted frequently enough that it doesn't become cariogenic, the dysbiosis doesn't occur. We couple this with our materials, because we have materials now that allow us to bind and adhere to this tooth structure. But it's important that, again, there are three sort of pillars in this golden triangle of making your minimally invasive restorations work. We really have to understand the histopathology, as I've said, of the different tissue types, whether you've got sound or carious enamel, whether you've got infected or affected dentine, and you need to really know that histology. You have to couple it with the modern chemistry of our adhesives and adhesive materials. And most of our materials are biointeractive. So they actually elicit a response to the tissues, and there is an interaction between the chemistry of the material and the histology of the tissues. And of course, as we keep practicing and working with patients, we get more and more skilled using these minimally invasive operative skill sets, and that we keep learning until the day we retire. So I work in clinical practice as well as being a clinical academic at King's College, and I unfortunately still sometimes see patients like we're seeing on the screen here with these sorts of images with gross caries. But we are acutely aware that if you section through a lesion, we can see the sort of cavitated area here with the carious enamel, the enamel dentine junction with the darker brown, contaminated, soft, wet, necrotic caries infected dentine. And then it gradually changes to caries affected dentine, this zone, which is repairable by the dentine pulp complex with the pulp chamber just off the screen. And if you think about how excavation principles have changed over the years, only 2 or 3 decades ago, people were cutting cavities to this sort of extent, cleaning the cavity out, making sure the margins were all healthy. We then became aware that this wasn't so relevant, and actually the texture of the dentine becomes more relevant. And so the dentine is sort of leathery, we can sort of retain it. So we retain the affected dentine. But actually we've shown now that you can go really minimally invasive, and there's many studies, clinical trials looking at sealing in the whole content of dentine caries and essentially putting a lid over the top that seals at these healthy margins that I'm showing you on the screen here with sound enamel, because that's where we get the peripheral seal on good quality histology. And our materials are getting cleverer and cleverer and cleverer at providing these interactions. So we can see an example here on the top left of a lower molar that's carious. We can see the shadowing, we can see some cavitation there. And on the radiograph, we can see the extent of the lesion in that lower second molar. If we outline the pulp chamber, we can see that in red, and the radiographic extent of the lesion shows how close it is to the pulp. If we carried out conventional complete caries removal, there is a significant risk that we would expose the pulp, as we can see here. And we used to think this was not a major problem. We could dress this direct pulp exposure, usually with a setting calcium hydroxide paste, and then place the restoration. And we thought this was fine. Clinical evidence shows us that after 5 years, nearly 50% of these teeth die, the pulps die. And after 10 years, that goes up to 80 to 90%. So giving a pulp a headache like this with a drill or a spoon excavator is not a good idea. So if we go back to the radiograph, we can see if we do selective, minimally invasive caries removal, just removing the necrotic, soft, wet outer zone of infected, bacterially contaminated dentine, we can still provide a high quality peripheral seal, as we can see here, around that enamel, and we can place a good quality restoration to fill that tooth. So again, we see examples here of the difference between complete caries excavation or near complete caries excavation on the left, compared to selective caries removal on the right, but still with the periphery cleared to allow that peripheral seal of adhesion with our biointeractive materials. Coming to the end of the presentation, we also need to think not just about patients who are presenting with new lesions, but many of our patients are going to have existing lesions that have been treated with restorations. And we then need to consider the maintenance of the tooth restoration complex. It's never the restoration on its own. It must be considered together with the tooth, the vital pulp, etc. So it's always the TRC, the tooth restoration complex. And the minimally invasive approach is to look at the 5 Rs, where we can review, refurbish, reseal, repair, or replace. And there's some references on the bottom of the screen there to guide you through the detailed protocol. I haven't got time to go through that with you now. But in overview, clinical photography will be able to allow us to look back at how restorations have performed and how they've changed over time. And if you looked at just the 9-year image here and showed newly qualified dentists, many of them would want to remove the restoration and start again. Whereas if you've got the sequence of images, you can see, apart from some surface wear, there is nothing really wrong with that restoration. Similarly, this left image, many newly qualified dentists would argue this should be replaced, whereas it required just a surface polish, a refurbishment, and the restoration is absolutely fine. Margins can become deficient. On these tooth-colored restorations, we can see more clearly, but even around the amalgam here, we can see deficiencies. And in my generation, we were taught to remove the whole restoration and start again. Whereas now we have cleverer materials, we can handle the defects in isolation and reseal these margins. And this is a perfectly effective, minimally invasive operative intervention. And as you can tell, we're gradually becoming more and more invasive when the damage is greater, where the cusps break off or parts of the restoration break, these can be repaired. And obviously, there will always be clinical situations where restorations require full replacement. What the message of this slide is really, don't jump straight to replacing restorations when there are a whole series of other more minimally invasive approaches that are just as effective. So if we're looking at the consensus guidelines, the consensus approaches that we have in caries management, over the last 5 or 6 years, there have been several papers published looking at guidelines with this aspect, and I've got some of them on the screen there. We've already mentioned this when to intervene in the caries process paper, but we also have others that you can see on the screen, really giving an overview of how we can manage carious lesions. It's never black and white because there's so many variables involved. We always, as clinicians, have to make an assessment with our patient and all those factors. But at least these papers exist that we can read to actually hang our ideas and our principles on. And I think this is really important. We're looking at older adults, we're looking at children, we've looked at patients with anxiety, and so on and so forth, as to how to sort of really manage the carious lesion and the caries process. So I direct you to these references to read at your leisure. An important paper that we've just about to publish in Dental Update in the United Kingdom is looking at minimum intervention oral care and how it is implemented by the different oral healthcare team members. And I think this is really quite relevant. And here's some graphics that are taken from that paper. Again, this is that representation of minimum intervention oral care with the 4 domains that I've already highlighted to you: identify, prevent, minimally invasively restore, and recall. And if we look at each of those under identify, we can see how the different team members can be involved in the different processes here. Dental nurses, hygienists, therapists, extended duties dental nurses, etc., etc. If we look at prevention and control, again, we can see all the different behavior change aspects, the micro-invasive approaches can be handled by different members of the team, not always just the dentist. Of course, the therapist, the dentist, and maybe the hygienist can get involved with the minimally invasive restorations. And again, the whole oral healthcare team gets involved, whether face-to-face or whether it's online, looking at that recall strategy, reviewing and reassessing the treatments that have been carried out. So this sort of highlights how we can embrace the oral healthcare team and how we need to embrace the oral healthcare team to actually deliver better oral health using the minimum intervention oral care framework. You'll be aware of the Careys Care International and the 4D approach that certainly underpins a lot of the work that's been done in ACFF. This is work that was carried out by Nigel Pitts and a huge team of people over the years. And this is the 4D model, where you have determine, detect, decide, and do, which are highlighted around the different cogs here. And you can see, it's getting a little bit crowded. We've got the papers there that was published in the British Dental Journal that I helped co-author, and of course my piece on minimum intervention oral care. And we can see how this CCI 4D approach is actually the caries management protocol that fits within the minimum intervention oral care framework. And as you can see here, I'm bringing up the different domains, the 4 domains of MIOC, and how they apply and overlay on top of this caries management protocol. So I say again, the MIOC framework actually underpins everything we do, and then we can start to fit in the different protocols to manage caries, periodontal disease, tooth wear, but they all fit within the 4 clinical domains. So coming to the end, just as a summary, we can see some of the evidence that I've been involved with, certainly, and books and chapters and papers and journals that highlight minimum intervention oral care, with the 2 British Dental Journal MI themed issues, which I would thoroughly recommend you to go and read. We have textbooks on the whole aspect of minimally invasive operative dentistry and MIOC, and we've got cases within this textbook, Clinical Problem Solving in Dentistry, that was published in the last year, as well as chapters in many other textbooks. And of course, there's plenty of other evidence out there. This is just a highlight of some of the things I personally have been involved with in recent times. Over a decade ago, I set up a distance learning master's program in advanced minimum intervention restorative dentistry at King's. And it is really the only one of 3-year masters, distance learning masters, that's available, both to therapists and to dentists at the moment. And we are looking at opening it up to other members of the oral healthcare team. And we are actually recruiting for January entry for anybody who's interested. Please, if you just Google King's AMID, the website will come up, or you can scan the QR codes, it will take you straight there. Please do look at this program if you're interested to learn more about how best to deliver minimum intervention oral care, and looking at all the domains and looking at the technologies and the materials and the clinical skills, the medical legal aspects, clinical photography, business management, all the aspects that allow you to provide the best healthcare to your patients. So hopefully I will see some of you on the program in the future. So with that, I'd like to thank you so much for your time to listen to my short presentation about minimum intervention oral care. And I hope I've whetted your appetite to look into this in more detail. Thank you so much for your attention.